Hi, I'm Dr. Matt Skalski, and in this video I want to go over the normal radiographic anatomy of the knee with you. So to start here, these are the four most common views that you're going to encounter, which are your lateral view, your A to P view, your tunnel view, and your sunrise view, otherwise known as your tangential view. And let's just begin here with the A to P view, which I've got my 3D model here over on the side to help us kind of correlate some of this anatomy. So let's just start with the femur and talk about what we're seeing here. Well, one thing you might notice is that you actually see the condyles really well through the femur. And so you can think of this as you're looking through it, or as you can see here, like they're coming out right at you. And they kind of curl around like this. And so that kind of prominence gives you this cortical edge that you can see. And sometimes you'll see one better than the other. But that's what these lines are that I'm outlining. And then in between those, that's our intercondylar notch. And that space, you can see, sometimes you can make out actually these little nutrient foramina which come in through there. And so there's a little porosity which can almost look like moth-eaten pattern of destruction. And you might notice that there's a similar type of appearance up here because there are similar nutrient foramina in the supracondylar region, both anteriorly above the trochlea and posteriorly here as illustrated. And out here laterally, then we have our epicondylar regions. And then depending how the knee projects, we might actually see the popliteal fossa here nicely, but we'll actually see that a lot better on our tunnel view in a little bit, because on the A to P view, you can see that the orientation of the popliteal groove is kind of like this, and the condyle almost covers it up a little bit here on the edge. And so that makes it kind of hard to make out. And the metaphyseal region flares out like all metaphyses do, and then transitions into the physis. And we often will see a bit of physeal scar where we have a little bit of remnant calcium where the physis used to be when we were developing, project across this way. And the patella, of course, we'll see through the femur, and then this whole area past the physeal scar is the epiphysis. We also see the physeal scar here on the tibia and the fibula as well. And so now let's talk a little bit about our fibular anatomy. Well, we have the medial tibial plateau and the lateral tibial plateau, and so these make up the medial and lateral compartments respectively. And oftentimes you'll hear people, when they're talking about the knee, talk about the tricompartmental, because we have three compartments: the patellofemoral and then the medial and lateral compartments. And so when you want to refer to them all collectively, oftentimes it's easiest just to say tricompartmental. So the medial tibial plateau and the lateral tibial plateau do project a bit differently. You can see that this tibial plateau on the lateral side, we kind of see that nice and tangentially across the surface of it, but we actually see this one a bit obliquely. So these are a little bit tilted relative to one another. You know, they're not going to be projected quite the same way because they're not at the same angle. And so that's just something you may observe. And the mistake I see a lot of people make here is that when they're looking for joint space narrowing, they look between, the back edge of the tibial plateau here, and they're saying, maybe there's joint space narrowing, but we should actually be kind of looking more towards where the weight-bearing sclerotic line is here, okay? And so the medial compartment often will have a pretty dense amount of sclerosis just because that's the weight-bearing compartment where most of our weight is being distributed across, so you have to have a bit more calcium there structurally to support that. All right, so that's our tibial plateaus, and on the margins of these, they should be nice and smooth and round like this, and then if there's anything more than that, then we'll call osteophytes to some degree. And so dividing the tibial plateaus is the medial tibial eminence. And so the tibial eminence has two spines, as you can see here. We have a medial tibial spine and a lateral tibial spine. Okay, and so those are kind of what those two spike-like projections are in the middle. Sometimes they'll be a bit bigger if there's some degenerative changes. Otherwise, they should be kind of small, and sometimes even maybe not even quite as sharp as these ones are. All right. And one thing I actually forgot to point out with the condyles is when we're looking at the condylar articular surface, we want to make sure that it's nice and smooth and flat to convex across the surface here. But you'll notice on the lateral side here, we almost have two different contour lines because we're seeing the junction between the trochlear articular surface and then the condylar articular surface. And so between those two is called the condylopatellar sulcus. And we do see that on the lateral side sometimes more prominently. All right. And so then we've got our metaphyseal region of the tibia here. And the fibula, the proximal portion here is the fibular head. And sometimes, depending on people's shape of their fibula, you might see it look like this, which is kind of more like the tibia, but sometimes you'll actually see a separate cortical line come in here separate from over on the edges here. And that's because if you look down at the cross section of the fibula, oftentimes it's going to be kind of more T-shaped. And so you'll see these cortical lines here, and then you'll see these cortical lines project separately. And so sometimes people mistake that for a periosteal reaction or something like that. I'll show you an example of that here in a minute. All right, and then notice that the fibula is actually posterolateral, so we're going to see it projecting over top of the tibia a little bit here in a straight A to P type of projection. Okay, so let's talk about the lateral. And my illustration here shows a lateral with the knee in full extension, but ideally when we're taking a lateral knee radiograph, we want to see about 45 degrees of knee flexion because what that's going to do is it's going to put a little bit of tension here on our patellar ligament, which we can see the posterior surface of here, and then maybe we can make out the anterior surface junction with the subcutaneous fat. And when you do that, then you also kind of string the quadriceps tendon away here so that we can get a good assessment of this kind of suprapatellar region to see if there's a suprapatellar joint effusion. And so like we can see in this case, we'd like to see a little collapsed area of fluid density within the suprapatellar fat to tell us there's no distension of our suprapatellar recess or bursa. And if our knee is too extended or too flexed, then it makes it much harder to assess for that, and that's an important secondary sign of trauma or other causes of joint effusion that we need to be sensitive to detecting. Okay, and so in this case, of course, it's not distended. This is a nice lateral, and we can see that this is collapsed down here. All right, and so the tibial tuberosity is where our patellar tendon or ligament attaches, and so you can see that kind of bumps out here to give us this nice surface to attach onto, and then the other end of it is at the patellar apex down here, and then the top of the patella is actually called a base. Some people will call this the superior and inferior pole of patella, but technically it's the apex and the base. And so the patellar articular surface runs from here to here, and the portion down here is non-articular. And this big triangular region of darkness is actually fat. That's why it's darker than the surrounding tendon, which is fluid density. And this is called Hoffa's fat pad, is this kind of triangular region of fat beneath the patella. And you'll notice the patellar articular surface, we can actually see a couple different lines projecting down here. We see the median patellar ridge most posteriorly, and then we see the medial and potentially the lateral facet kind of summate to create this other cortical line. And so that median patellar ridge fits into the center of the trochlear groove, which is here. That's the deepest portion of our trochlea, and then we can see the condylar ridges kind of projecting past that. All right, and so that intracondylar region that we saw on the A to P view, we can see really nicely on the lateral view is this dense sclerotic line. So this is the roof of that intercondylar notch, and this kind of dense line we call Blumensatz's line. And then notice on the lateral femoral condyle, that condylopatellar sulcus we saw in the A to P that I pointed out, that's that little divot here. And we do actually look at this closely on our lateral knees because if that's too deep, that could be an impaction fracture from a pivot shift injury, which could indicate an underlying ACL tear. All right, and so our condyles, of course, curve up here, and then depending on how oblique they are, sometimes you can see the gastroc attachments here a little bit more prominently, and maybe even the medial adductor tubercle, which I actually forgot to mention on the last view here. So this is our adductor tubercle here, and as you can see, depending on the size of it, in this case, pretty normal size, we don't see it that well, but sometimes you'll see that project a little bit more prominently, and that's also a normal anatomic finding. And one other thing I should point out is that if you see a little density here like this, that's called an os fibella. That's a little normal sesamoid that will get deposited in the lateral head of your gastroc in about 10% of individuals. All right, so that's the distal femur anatomy. Now let's talk a little bit about the proximal tibia. And so the proximal tibia, we already talked about the tibial tuberosity, and those tibial spines we saw on our A to P are going to project here, and they're side by side, so they're going to be pretty well superimposed if it's a good lateral. You can see there's kind of a little bump here for our ACL attachment, which is going to come up in this orientation. And then notice that as they come back here, we kind of get this sloped portion along the back of our tibial eminence. And if we look at that here, you can see that this sloped portion is kind of oriented like this because that's where our PCL attaches, and it's going to come up here and then attach onto the intercondylar region, and their ACL is going to be coming up from the anterior side and then attaching up over here like this. All right, so those are our tibial spines, and we want to look back here to see, if there's a PCL avulsion and other pathology potentially can hide back there, and then the tibial plateaus kind of extend back to cover up that region, and you can see, how they would extend a little bit past this little deep region. Maybe if I rotate the model here, you can see that a little bit better, how these extend past this kind of sloped portion behind the tibial spines. All right, and so here's the kind of like a styloid process of our fibular head, and let's see, is there anything else I wanted to cover on this view? I think that's about it. Oh, and I just wanted to point out again here that patellofemoral joint here, this is why we're seeing kind of the median patellar ridge project deep to the kind of the edge of the other medial and lateral facets, giving us these kind of multiple cortical lines here. And then similarly, we see the cortical line from the center of our trochlear groove like that, and then we'll see the condyles kind of projecting a bit more anterior. All right, so let's look at a slightly oblique lateral knee. And I actually don't even mind when I get a little bit of a obliquity in my lateral knees, because it does sometimes make it a little bit easier to separate out the medial and lateral condyles. And again here, we can see our medial condyle projecting a bit more posteriorly, and then we can see our kind of adductor tubercle and then our gastroc attachment up here as well. And again, we see in this is a different individual. They also have a slight condylopatellar sulcus there, and maybe we even see that kind of sloped portion behind the tibial spines even a little bit better. And we know that they're oblique kind of this way because of that kind of anterior movement of the fibula kind of shows you, how that rotation is occurring. If the fibula was projecting more posteriorly, then, we would be seeing the lateral femoral condyle projected more posteriorly here. All right, so, and that's the case in this image. I forgot I added this one. And so look at how nice we can see the proximal tibiofibular joint here. And so we know that this is going to be our lateral femoral condyle projecting back here. And oh, look at that. We got the beginning of the formation of a little os fibella depositing a little sesamoid, the posterior patella, if you will, to kind of help that kind of mechanical transition of force around the corner here, just like our patella does around the corner of the knee when we're flexing and extending. All right, so the sunrise view here is actually an important view to look at if we're looking for a patellofemoral disease, and it gives us a really good view of the different facets of the patella. We can see that we have this really long and shallow lateral facet, then we have our median patellar ridge that's deep in the trochlea, and maybe I can just make that a different color, and then we see on the medial facet, it's a little bit steeper here. And this is one of the reasons that when we have a patellar dislocation, it tends to go laterally because it's just a less of a ridge to get over to go that way, because we don't have this kind of steep portion kind of blocking medial translation. There's other reasons as well, of course, the location of our tibial tuberosity and some other factors. But that's how you can kind of tell which side is which when you're, if you can't see the fibula or some other orientation thing. And then sometimes we'll see a little odd facet here on the medial side, but the main thing you're looking for is the steep medial facet and that shallow, long lateral facet on either side of the median patellar ridge. And another thing that we want to look for is the depth of the trochlear groove here, because sometimes that can be shallow and cause patellar maltracking and instability and things like that. All right, so that's the patellofemoral joint and the trochlea. So now let's talk about this tunnel view. And I think it's important to kind of understand how this tunnel view is taken. So the patients, for most of the times that when this is taken, not always, they're going to be prone. That's the standard way to take this, with the knee flexed up like this so that we can shoot down right along that Blumensatz's line, kind of parallel to the roof of that intercondylar notch. And the way I drew this arrow is probably a little bit too steep. Probably down like that would be a little bit more accurate. And then, of course, our cassette has to be shifted down here to catch that. And so what we're going to see in the end then is that kind of flexed knee position where we get a good shot of our medial and lateral compartments, but then we're seeing right down this tunnel between the two condyles. And so you can see the roof of that here. And so I actually like this view sometimes because it'll show you if there's kind of big spurs kind of coming off the condyles into that intercondylar region, which could be symptomatic potentially. We can see the tibial eminence and the tibial spines here really nicely, and we get, like I mentioned, that really great shot of the joint spaces. It's not weight bearing, so that's the main thing you have to consider, is that we tend to always do our A to P knees weight bearing, because that's what's going to give us a true representation of the load bearing joint space, which may be artificially widened when people are non-weight bearing. And once again, notice that we're not seeing the tibial plateaus projected symmetrically here because they're not at the same angle. And then this is a case where I wanted to show you that fibula kind of having that T shape, as I mentioned, where we can see the cortex kind of coming out here, and then we see kind of these additional cortical lines. These aren't periosteal reactions or anything like this. That's just the kind of center portion. And so again, I'm going to draw the cross section of the fibula here. And so this fibula is going to be kind of like this. And so we're going to see this cortical line out here laterally being the edge of the fibula, and then we see this kind of more medial portion here corresponding to these. And then up here we can kind of see that separate off a little bit more laterally to get this edge. We do get a better shot of the popliteal groove here because now we're kind of turning that popliteal groove so that it's right along the same contour as our central ray. All right. So just a few kind of mistaken laterals, just to show you for reference, what a bad lateral would look like. So this lateral is flexed to 90 degrees, way too flexed, and so we're getting bowstringing of our quadriceps tendon right up here against the femur, and it's going to compress that suprapatellar recess or pouch or bursa, however you want to refer to it, and it's going to make it very difficult, if not impossible in some cases, to look for that joint effusion, which is where we find that. And similarly here in extension, now we get this kind of folding and redundancy of our lax patellar ligament. And it makes it hard to see, is there a joint effusion here? Is there not? Maybe I can see, a little bit of physiologic amount of fluid here, but, our confidence is going to go down in those scenarios. And, this is also somewhat oblique lateral, so a number of different issues with that one. All right. And so one last point here, which I think is an important one that I actually get questions on relatively frequently, is that on our A to P views, our tibial tuberosity can project over here laterally and mimic a periosteal reaction or some type of lesion like an osteochondroma. Or, people come to me with all sorts of concerns, but this is an expected normal finding to see the tibial tuberosity projected a bit more laterally here. And truth be told, in some individuals, it can actually be pathologically lateral and, predispose people to patellar dislocations and these types of things. But if you see this, nothing to get worked up about. That's just a normal tibial tuberosity. You can safely ignore it and move on with your day. And you can even see the other edge of the tibial tuberosity kind of projected over here, because there is a little bit of a contour change, which in some people, depending on the size of their tibial tuberosity, may actually make it visible on the A to P. So that's all I wanted to cover here. If you enjoyed this, you learned something, hit that subscribe button so you don't miss my future videos. Hit the bell notification if you want to know when I publish stuff. Hit the like button. That's super helpful to me. Leave a comment if you thought I did a good job, or if you thought I missed something or something you want to learn more about. That really helps me grow my channel and keep making content like this. So thanks for watching, and I will see you again soon.